So one size does not fit all, and what I'm going to talk about that is immediate resuscitation, as written in the surviving sepsis guideline as well, is a key to survival in shock states. Now our aim is to maintain adequate VO2, DO2 to the tissues. To achieve that, we have several tools, and there are several potential therapeutic targets. However, choosing just one target and one parameter may not be good. Therefore, I propose a holistic approach, and I believe it's the best way to conquer shock. So if you are intrigued by the topic, then please stay with me, fasten your seatbelts. I'm going to take you through our multimodal individualized concept. So everything is revolving around oxygen in our body. You've seen that slide several times, but it's an everlasting and evergreen slide. So everything is revolving, and without going into the details, it's a balance between oxygen delivery and consumption, and you should teach your resident doctors for this equation. They should know it by heart, because they will understand why patients get into trouble. And they will also understand that the only reason we give fluid, blood, and oxygen supplementation to our patients is to increase oxygen delivery. And the main benefit in this regard of giving analgesia and sedation to our patients, that you reduce oxygen demand, oxygen consumption, and by doing so, you may just regain balance. Now, in addition to the VO2, DO2 balance, there is one term that is also very important to bear in mind. It's hemodynamic coherence. That paper was written by John Inchi, standing in the middle between Jean-Louis Vincent and myself, cruising on the Bosporus on a Turkish conference. And hemodynamic coherence means the coherent interaction between macro and micro circulation. In other words, because we are correcting systemic hemodynamics, macrocirculation, it only makes sense if it is followed by the correction of regional and microcirculatory perfusion and oxygen delivery. So John wrote this article in 2015, and 1 year before that, with Christian and Marci, we wrote this chapter in the annual update, a book that is released every year in Brussels, and it was released. And in this is how we put this. We called it the hemodynamic puzzle. And what you see here, that you can measure pressures, you can measure flow, you can measure hemoglobin, so you can measure components of oxygen delivery. But whether these parameters are adequate for your patient in this given moment of time, you must measure the receiving end, the consuming end. This is why you have to put this in context with lactate, venous saturation, diuresis, organ perfusion, and so on. So there is no way out, and I try to explain and convince you that there is no way out at the bedside than to put everything together in a holistic approach and then make a decision accordingly. So let's take it to the bedside. A story of a 60-year-old man who is admitted via A&E with abdominal pain and was taken to the operating room for emergency surgery because of free intra-abdominal air. In his previous medical history, there was ischemic heart disease and hypotension, nothing that severe, by the way. So the patient was in the operating room. We gave oxygen, we put 2 peripheral lines in and an arterial line. Everything was fine regarding heart rate, blood pressure, and hemoglobin, so we performed rapid sequence induction, and the surgery started, initially laparoscopy, and they converted it into laparotomy. As we went along, the patient became hypotensive, 95/40. So the potential causes of a regular or slowly developing hypotension in the operating room are twofold, but because of the low diastolic pressure, we mainly thought it is some sort of vasoplagia. However, you cannot really exclude hypovolemia at this stage. Nevertheless, I'm sure you agree with me that this is a blood pressure that needs to be treated. So what would you give? You can explain why you would give fluid, dobutamine, patient has heart condition, fluid and dobutamine, noradrenaline, fluid and noradrenaline. So both can be good or bad, you know. So, but we decided to give fluid and noradrenaline, and the patient received a bolus of crystalloid, and then we started noradrenaline infusion. Now, possibly some of you will ask, why both? Most of the guidelines say give fluid first and then vasopressor. Well, I don't think it's right to wait for the fluid to exert its effect, because we have strong data. It is a large American registry data of tens of thousands of patients that intraoperative hypotension has an effect on acute kidney injury and myocardial injury in the postoperative period. In fact, if the blood pressure is lower, the mean arterial pressure is lower than 65 millimeters of mercury, regardless whether it was only for 1 minute, lasted 1 minute or 10 minutes, the chance of developing acute kidney injury and myocardial injury increases several-fold. So avoiding hypotension or treat it as soon as possible is of utmost importance. So this is what we did, fluid and noradrenaline, and you can see that at 10 mics per minute noradrenaline, the mean arterial pressure increased to 75 millimeters of mercury. So you can ask me whether I was happy at this stage. And the answer is that if I were one of these doctors, this is a Fenice study we did 10 years ago. And when we asked intensive care physicians on what basis do they give fluid to their patients, and 60% of them said that it is hypotension. So if I were one of them, 60%, I would be happy. But I know physiology, and I know that mean arterial pressure has got nothing to do with cardiac output. It can remain in the normal range when the patient is in cardiogenic shock or in a hyperdynamic shock with high cardiac output. So mean arterial pressure doesn't really tell me much about, especially not oxygen delivery and consumption. So I don't know. And in order to answer this question, whether I'm happy or not, the next question is this mean arterial pressure associated with adequate perfusion? So it's because it's all about perfusion, and you can assess the vital organs and the periphery and the global physiology according to some parameters. The best indicator of a well-perfused brain, if the patient is awake, GCS-15, is difficult in the operating room, obviously. ST segment changes in ECG can refer to heart hypoperfusion. The end-tidal CO2 is a very good marker of lung perfusion, or if you calculate the dead space ratio. Urine output, hourly urine output, is the gold standard of monitoring kidney perfusion. You can check the peripheral perfusion by capillary refill time, periphery to core temperature changes, and microcirculatory perfusion via different tools. And you can also assess global perfusion when you measure serum lactate level, pH, bicarbonate. You can measure central or mixed venous saturation and the PCO2 gap. So now I will focus basically, because these are possibly the most easier parameters, and I will only focus now a bit on SCVO2 and PCO2 gap. So again, without going in depth of physiology, just one thing I would like to draw your attention to is this figure, which shows what happens if, for whatever reason, oxygen delivery starts to decrease. Let it be hypovolemia, bleeding, myocardial dysfunction, whatever. Then you can see that although DO2 is decreasing, but up to a critical point, that dot on the y-axis, the VO2, doesn't budge. So there is no problem with oxygen uptake. But beyond that critical point, when all compensatory mechanisms are exhausted, then any further drop in DO2 will be associated with hypoperfusion, and the moment delivery cannot fulfill oxygen demand is termed shock. So it's easy to understand that we are now interested in this part of the figure when the body is taken up the same amount of oxygen, but if the DO2 is decreasing, the remaining oxygen will be less and less. Therefore, a drop in DO2 when the patient is in that part of this curve, of this relationship, should be detected by SCVO2. The other parameter is a PCO2 gap. This is late Max Harry-Weil, who is a genius in shock physiology and shock research. And what they showed that The PCO2 gap is usually under physiological conditions, it's about 6 millimeters of mercury. And in patients who underwent cardiopulmonary resuscitation, the PCO2 gap was found 42 millimeters of mercury on average. And the explanation is that the total CO2 production, similar to oxygen consumption, the equation of oxygen consumption, equals to cardiac output multiplied by the venous minus arterial CO2 content. And with a little trick, we can convert the content to PCO2. So reorganizing this equation, the CO2 gap equals to CO2 production divided by cardiac output. So the CO2 gap can only increase when the CO2 production doesn't change grossly if the cardiac output drops. So an increased PCO2 gap refers to low cardiac output. So this is what we did. We took 2 blood gases and 1 arterial, which is remarkable, you can see, apart from a little bit of elevated lactate, but otherwise normal. But putting the next central venous blood gas next to it, the patient had the high PCO2 gap and an even worse SCVO2 of 49%. This patient is in dire straits, in serious trouble. So putting that again, explaining that a little bit, elevated lactate refers to anaerobic metabolism, low SCVO2 means inadequate DO2, and the high CO2 gap refers to inadequate cardiac output. We know how to treat it. You can give fluid, you can give blood, or positive inotropic agents. Which one would you choose? Well, at this stage, it was early days during surgery, we decided to give a bit more fluid to that patient. And after 2 lots of boluses of fluid, nothing really changed. A little bit of improvement, but not a big deal. So what would you do then? Would you carry on experimenting with a bit of dobutamine, a bit of fluid, a bit of this, or you would need more information? And I think this is the time, because diagnosis can wait, but cells can't. This is the time when we need more information. And what we did, we attached this sensor, the ProAct sensor, to the already indwelling arterial line. And with this, we can get results on cardiac output, stroke volume, pulse pressure variation, and so on. So reading the first variables, cardiac output is just about normal, stroke volume is low, and pulse pressure variation is high. So the patient is volume responsive without doubt. So you've seen the other physiological parameters. So what would you do? Obviously give a bit more fluid. And half an hour later, there was some improvement, but the stroke volume was still low. And the SVO2 is still lower than it should be in an anesthetized patient, and the PCO2 gap was also high. Now, we've given enough fluid, the PPV has normalized, the patient is not volume responsive. So what would you do? So this is the time when we blamed contractility and we added dobutamine to the picture. And by doing so, with dobutamine, cardiac index stroke volume increased, although stroke volume not normalized, and measuring again SCVO2 and blood gases, then the SCVO2 was getting up, it was improving, but the patient became volume responsive again, and the SCVO2 is still low, and the hemoglobin level dropped due to dilution of the lot of fluid that we gave, plus a bit of bleeding during surgery. So the patient is volume responsive, and we have some VO2-DO2 imbalance as indicated by low SCVO2 and low hemoglobin, although it is higher than 7, but we decided to give some blood. And after just 1 unit of blood, everything started to normalize. The catecholamine requirement was, we were able to reduce it. Stroke volume entered now the normal range. SCVO2 almost normalized. Usually it should be around 80% in anesthetized patients, and the hemoglobin, of course, increased. So, was I happy at that time? Thank you, I was. I was quite happy. And then, towards the end of surgery, or the end of the full story, the surgeon closed the wound, took off his gloves, and left the operating room, and everything got back to normal. So, that was the surgeon, obviously, which was the reason of the hemodynamic instability. So what was missing in this detailed story of mine from the monitoring in the OR? It was depth of anesthesia monitoring. You can kill a patient by giving a lot of anesthetic agents, right? You can cause hemodynamic instability. Not measuring depth of anesthesia is a mistake. And even more than 10 years ago, in one of the first ERA's guidelines, it received a strong recommendation to measure some sort of a depth of anesthesia in the operating room. So finally, it is a complicated picture. This is what we published with Jan a few years ago, and Bernd Zaugel. This is a very complicated figure, and it is a complicated story. So basically, you have a lot of alarming signals. It is not just blood pressure, not just heart rate. You can take a seemingly stable patient, you take a venous blood gas, and oh my God, there is a serious problem here, and then you have to look around. And then you have to put everything in context, and then make a decision whether this change is clinically relevant or irrelevant. If it's relevant, you should act. If it's irrelevant, you just observe. So, there is no replacement yet of you guys, a thinking physician. You dial in all information, spice it with your experience, and then make a decision. Yet. But, I have already referred to that. This is what I saw in China. This is intensive care solution, and that's me there looking like, you know, like in another world. And I was in another world. It was called China, by the way. And so artificial intelligence is here. I'm sure we will see that and use that in the near future. And possibly even next year on the Next Steps East meeting, that's going to be in June, please put it in your calendar, we may hear much more about AI, even more than we heard today. Thank you.